loss of the supratarsal fold. And if the zygomaticomaxillary complex comes down, the overall volume of the orbit will increase. Once the volume of orbit will increase, the eye globe, either it will come downward or it may also go inward, especially if there is associated orbital floor fracture, and especially if the orbital floor is fractured from its posterior aspect. Then the contents of the orbit, they will go down towards the maxillary sinus, as a result of which the the eye globe, it will move posteriorly, and this posterior positioning of the eye globe, it is labeled as anophthalmosis. This is also one of the feature of the zygomaticomaxillary complex fracture. Then if the fracture is such that the zygomatic bone, it has gone inward towards the orbital cavity. If it has gone inward towards the orbital cavity, definitely the overall volume of the orbit will decrease. And what will be the result of this? The globe will not find place within the orbit. There will be less space for the globe, and it will move outward. And this outward positioning of the globe is labeled as exophthalmosis or proptosis of the eye. And depending upon the damage to the nerves present over there, like third nerve, fourth nerve, or sixth nerve, there could be associated features along with these, like loss of direct light reflex, loss of indirect light reflex. Indirect light reflex is also called consensual reflex, and loss of nasociliary corneal reflex due to damage to nasociliary nerve, or loss of accommodation reflex. These two reflexes, they may get lost if there is damage to the sphenoorbital fissure, because these nerves, they come into the orbit through this sphenoorbital fissure. And if there is damage to the supraorbital supratrochlear nerves, then this forehead area, there will be paresthesia or anesthesia of the forehead area and the ipsilateral side. Then coming down towards the zygomaticomaxillary complex, there could be gross swelling of the periorbital swelling also, and the patient may also present like in the picture of this female with some suture laceration, or there could be abrasions and some ointment applied over there. If there was bleed through the nose, then there could be nasal packing also. Why the nasal bleed will be there? In case of zygomatic bone fracture, there will be ipsilateral nasal bleed if there is ipsilateral zygomatic bone fracture. In case of bilateral zygomatic bone fracture, there will be bilateral nasal bleed. In case of Leaford 1 fracture, in case of Leaford 2 fractures also, you will find bilateral nasal bleed. While nasal bleeding will be there, when there is fracture to zygomatic bone or zygomaticomaxillary complex fracture, once there is Leaford 1 fracture or Leaford 2 fracture, these fractures, the fracture lines also come through the maxillary sinus. In all these fractures, Leaford 1 fracture, Leaford 2 fracture, and zygomaticomaxillary complex fracture are in case of orbital fractures. Someone may also ask from you in the form of MCQs that which of the fracture which is the fracture which is not involving the maxillary sinus, and the options could be Leaford 1 fracture, Leaford 2 fracture, zygomaticomaxillary complex fracture, orbital fracture, and Leaford 3 fracture. Here Leaford 3 fracture doesn't involve the walls of the maxillary sinus, and once the fracture of the walls of maxillary sinus is there, definitely there will be bleeding. And where this blood go, this blood will come into the cavity of maxillary sinus. Once the blood is in the maxillary sinus and it gets filled with the blood, as you know, the maxillary sinus it opens into the lateral wall of nose through its ostium present in the middle meatus, in the hiatus semilunaris. Hiatus semilunaris is present in the middle meatus, and middle meatus in the lateral wall of nose, and this lateral wall of nose, it forms the medial wall of sinus, because the sinus, orbital, all these are neighbors to each other. The maxillary sinus, its medial wall is the lateral wall of nose. The roof of maxillary sinus, it is the floor of orbit. Anterolateral wall of maxillary sinus, if it gets disrupted, directly there will be communication towards the oral cavity. And posteriorly, If maxillary sinus get disrupted, then there will be communication towards the trigopalatine fossa or infratemporal fossa, etc. Okay, once there's blood into the maxillary sinus, and this blood, if goes through its ostium into the nose, from nose the blood may come out in the form of epistaxis. That's why there could be ipsilateral epistaxis or nasal bleed in case of zygomaticomaxillary complex fracture, and bilateral bleed in case of bilateral zygomatic bone fractures, in case of Lefort 1 fracture, in case of Lefort 2 fractures could be there. Like in these pictures also, there's downward displacement of the zygomatic bone, leading to flattening of malar eminence in the right area, right side, and infrabular chymosis also, and swelling in the area is there. And also in this patient, the second patient, again this whole zygomaticomaxillary complex has come down, and there's swelling as well as there's also flattening in this area, on the right side. In both of these patients, the fracture is on the right side. This is a case of gunshot injury, and here is the entry wound. In the left zygomaticomaxillary complex region, just from front, there is entry wound of the bullet, of the shotgun pellets or bullet over there. And after some time, when there's healing of this, there's scarring, and there is fibrosis of the tissue, and still there's depression and small hole, which signify the you can say the entry wound of the bullet. And there's also depression in this area, and that this distorted anatomy of this area. And this is the intraoral picture of the same patient. And when there is fracture of the zygomatic bone, there could be limitation of mouth opening. You could also know the mechanism why there could be limitation of mouth opening in case of zygomaticomaxillary complex fracture. If I can explain you, when there is fracture to body of zygomatic bone and it get displaced downward or inward, directly it impinges on the coronoid process. Once it impinges on the coronoid process, the downward, backward or clockwise movement of the mandible, it gets restricted. Just look towards my hands. This is downward and backward movement of the mandible. And my thumbs, these are you can say simulating the coronoid process. Once the mandible moves downward, backward, the coronoid process also definitely will move. And if there is no space for the coronoid process due to downward placement of the body of zygomatic bone, it impinges the coronoid process, then there will be restriction in the mandibular movement. Once the restriction in the mandibular movement is there, definitely there will be limitation of mouth opening. This is one mechanism. That is, the body of zygomatic bone, it impinges on the process, on the coronoid process. The second effect could be when there is lateral blow to the zygomatic arch, and the arch get displaced medially in the type like V type in fracture. Again, it will also has effect on the coronoid process. It also impinges on the coronoid process. Moreover, the muscles of mastications which move the mandible, they are attached to the mandible, but due to like masseter muscle, it get originated from the zygomatic bone and the zygomatic arch. Once the fracture of the zygomaticomaxillary complex is there, definitely it will also have effect on the masseter muscle, due to which there could be limitation of mouth opening. Moreover, in this specific patient, due to localized fibrosis of the area, there could be limited mouth opening. These are the mechanism behind that why limited mouth opening could be there in case of zygomaticomaxillary complex fractures. This is also one of the clinical feature of the zygomatic bone fracture. Moreover, if like in this patient, the patient also has some aesthetic problem, but sometimes the patients, they present late and there is no significant aesthetic problem to the patient. There are certain patients, but in most of the cases, there are aesthetic problems, there are functional problems, and there are also certain other associated problems like neurosensory deficit or damage to the nerves leading to neurosensory deficit or limitation of mouth opening. But there are certain set of category of the patients where there is no aesthetic problem in spite of the zygomatic bone fracture. There is only one functional problem in those patients, like limited mouth opening. This is the chief complaint of the patient due to which the patient presents to you. If there is no other significant problem to the patient and patient presents late to you and there is limited mouth opening, then one treatment option is the coronoidectomy. That is, remove the corona. We will discuss also later in the later slides. But to get relief from this limited mouth opening, the coronoidectomy could also be an option for management of such patients. Okay, while examining these patients clinically, this on the point C, the bird's eye view of the patient, that look from the above and behind by placing your fingers bilaterally in the malar eminence region. The side where there is zygomatic bone fracture, the area will be depressed. Once you place the fingers on that area bilaterally, the unaffected side, the finger level will be normal. But on the affected side, there will be depression in the area, and the finger will be relatively at some lower level, and at some lower level. Sorry. This is also one way of examining the zygomaticomaxillary complex fracture. That is, on the affected side, you will see that your finger is relatively at some lower level, which signifies the presence of malar flattening. Moreover, while examining, when you place your fingers at infoorbital area, there could be crepitus over there. The patient may feel tenderness in this area. There could be step deformity in infoorbital region also. And if you place your fingers intraorally also, like here in the picture D, then intraorally again there could be tenderness, there could be crepitus, there could be tenderness, there could be crepitus, and there could be step deformity in the zygomaticomaxillary buttress region also. And while examining the patient clinically intraorally, you may find chymosis in the mucosa present in the zygomaticomaxillary buttress region. And the presence of hematoma or chymosis in zygomaticomaxillary buttress region, this is called Gordon sign. This is also one of the significant features associated with zygomaticomaxillary complex fractures, also with the Leafwood 1 fracture, and also with the Leafwood 2 fractures. There could, like in this picture B, when the zygomatic bone comes down, there will be step deformity in the lateral orbital area, lateral orbital margin. Once you place in the picture E, once you place your finger inside the oral cavity, you may find crepitus or displacement in that area also. These are different features in one go. You can take screenshot of this picture so as to get an idea of all the features of the clinical features of the zygomaticomaxillary complex fracture. Like there could be periorbital edema or periorbital chymosis. Like here, I'm pointing this pic over there. This one, upper right pic. There is periorbital chymosis, periorbital edema, swelling and puffiness of eye, more common in Leafwood 3 fractures and very common in case of Leafwood 2 as well as 3 fracture when in combination, or in case of multiple fractures when there is Leafwood 3 fracture, Leafwood 2 fracture, and also zygomatic bone fracture when there. Here is the flattening of the cheek in this pic, also limited mouth opening, periorbital chymosis, flattening of malar prominence, why it occurs, we have discussed, And then flattening over the zygomatic arch could be there when there's lateral blow and arch goes inward. There will be flattening in the arch region also. Pain, the patient will complain, have a complaint of pain, and clinically when we examine, there could be tenderness and ecchymosis in the maxillary buttress, buccal vestibular, buccal sulcus region. This is Gorin sign, which I have described. Then deformity of the zygomatic buttress region can be appreciated when we place our fingers intraorally and intraorally. Once we examine, there could be deformity of zygomatic buttress. There could be tenderness in that area. There could be step in that area. There could be crepitus, grating sound over there also. And also repeating these features so that you can have a good idea of these. Deformity of infraorbital mark. You have to examine all the articulations of zygomatic bone while examining the zygomatic complex fracture. There could be pain, tenderness, step deformity at frontozygomatic area, all along the lateral orbital margin or frontozygomatic suture. Pain, tenderness, step deformity, crepitus in the infraorbital margin area, anywhere in the infraorbital margin, inside the oral cavity at zygomaticomaxillary buttress region, and laterally along the zygomatic arch region. These are the different potential points of damage or fracture of the zygomatic bone. But nowadays, due to high velocity injuries, there could be different patterns of the fractures of zygomaticomaxillary complex also. We'll discuss when I will show the cases. There are different types of fractures also than this usual pattern. And then deformity of orbital margin. Trismus means limited mouth opening. We have discussed in detail that why trismus or limited mouth opening in these patients could be paresthesia of cheek, definitely of not only of the cheek but also of ala of nose, lateral aspect of upper lip and lower eyelid region, and area over the malar eminence due to paresthesia and anesthesia of infraorbital nerve, due to zygomaticotemporal nerve or zygomaticofacial nerve. Due to zygomaticotemporal nerve, there could be paresthesia and anesthesia of the area, a non-hair bearing area of the temple. And then paresthesia of cheek. Epistaxis, we have discussed unilateral in case of unilateral zygomatic bone fracture, and bilateral in case of bilateral zygomatic bone fracture, in case of Leaford 1 fracture, in case of Leaford 2 fracture. Subconjunctival hemorrhage, we have discussed in unilateral or bilateral, depending upon the type of fracture. And okay, subconjunctival hemorrhage, it can occur in case of zygomatic bone fracture, in case of zygomaticomaxillary complex fracture, in case of Leaford 2 fracture, in case of Leaford 3 fracture, in case of orbital floor fracture, in case of orbital roof fracture, in case of medial orbital wall fracture, medial wall of orbit fracture. Then what could be the differential diagnosis of subconjunctival hemorrhage? Again, I am repeating, due to it will not be due to Leaford 1 fracture. Remember, again, it can be asked in MCQs that which of the fracture is not causing the subconjunctival hemorrhage. You will label Leaford 1. In case of Leaford 2 fracture, there could be subconjunctival hemorrhage because this fracture also involves the orbital wall or orbital rim. Then zygomaticomaxillary complex fracture or zygomatic bone fracture, there could be subconjunctival hemorrhage. Then supraorbital rim fracture or frontal sinus fracture or medial wall of orbit fracture, Leaford 3 fractures. These are different fractures which may lead to subconjunctival, remain red in case of subconjunctival hemorrhage. And reason I have described that there is direct perfusion of that blood from the atmosphere due to oxygenation. Then crepitus all along the fracture areas you may appreciate while palpating these areas. Displacement of palpebral fissure. This ocular fissure or palpebral fissure, especially from its lateral aspect, it may get displaced due to downward displacement of the zygomatic bone fracture, along with that Whitnall's tubercle and suspensory ligament of Lockwood, and then this palpebral fissure may get displaced towards the downward side. Then unequal level of pupils or pupillary level due to downward displacement of zygomatic bone. We have also discussed this one, that the globe will come down and the both pupils will have different level. Once the level is different, then diplopia will also be there. And the diplopia could be there. And as far as diplopia is concerned, there could be traumatic causes, there could be neurological causes. Among the neurological causes of diplopia, there could be damage to third nerve, fourth nerve, and sixth nerve. And as far as the traumatic causes are concerned, what could be the different traumatic causes? Like the fracture of zygomatic bone isolated or zygomaticomaxillary complex fracture, in case of LeFor-2 fracture, in case of LeFor-3 fracture, or in case of orbital floor fractures. If someone asks you the different traumatic causes of diplopia, then these are the causes. Again, I will repeat. Again, it will not occur in case of LeFor-1 fracture, because LeFor-1 fracture is low-level fracture and it is not affecting the orbit. LeFor-2 fracture, zygomatic bone fracture, zygomaticomaxillary complex fracture, LeFor-3 fracture, as well as orbital floor fracture or medial wall of orbit fracture. Once these fractures are there, due to displacement of bones, the globe may get displaced. This is one of the reasons for diplopia. Or once the fracture is there, the extraocular muscles which move the eye globe, they get entrapped within these fractured bones. They will also restrict the movement of the affected sided eye. Once the movement of the eye globe is restricted, then definitely there will be diplopia, because single vision will be when the both eyes will have same visual axis and will move in coordination. But once the eye globes, they are not moving in coordination and visual axis of both eyes get changed, then there will be diplopia. And these are different underlying reasons. And anophthalmosis, we have discussed that once the orbital volume get increased, eyeball may come down, may come in, go inward. Downward movement of the eye globe is the hypoglobus. Inward movement of the eye globe is the anophthalmosis. Outward movement of the eye globe is the exophthalmosis or proptosis. And an upward movement of the eye globe is the hyperglobus. And any of these features could be there in case of zygomaticomaxillary complex fracture also. Coming towards the radiological or radiographic examination, the standard are recommended radiographs for mid-facial fractures are the PNS view or occipitomental view, as well as the submentovertex or SMV or jug handle view. These two radiographs, that is PNS and submentovertex. These are the recommended radiographs for mid-facial fractures. But this is the radiograph of the previously we have seen the patient of gunshot injury, multiple pills. The purpose of placing these radiographs over there is to show you how these radiopic bodies can present in the radiograph. There are multiple. Where I'm moving this cursor, I will highlight this. There are multiple small shotgun pellets over there on the left side, and also on the PA view over there. Sometimes zygomatic arch can be appreciated to some extent on the orthopantomogram, OPG, panoramic view. The same, these are the different names for the same radio. Panoramic view, OPG, OPT, as well as an orthopantomogram, that is OPG. And especially if there is zygomaticomaxillary complex fracture along with lower face fracture also, then these radiographs will also become mandatory, because these two radiographs, that's OPG and the PA mandible. This is a PA mandible, this one, the other radiograph. These two are mandatory for lower face fractures, and in the lower face, mandible comes. And in the for the mid face, PNS view as well as the submentovertex view. And in case of complex fractures of the mid face, or in case of grossly displaced condylar fractures also, a comminuted mid face fracture, or orbital fractures, and in case of upper face fractures, these are different indications for CT scan. When you will go for CT scan of the facial fracture, or when there are multiple fractures of the face, grossly displaced fracture, or when there is panfacial fracture. Panfacial fracture means a fracture involving through and through all thirds of the face, upper third, middle third, and lower third of the face. Once these fractures are there, then you can go for CT scan. And with the advent of the new technologies, the CT scan has become the gold standard for managing the maxillofacial trauma. Then coming towards the standard recommended radiographs for mid-facial fractures, these are the PNS views. On the two over there on the left as well as also on the right. On the right side radiograph, this is the radiograph is drawn over. There are different lines are drawn. I will also discuss in detail these lines. You will have and get an idea of these lines also. First, I will just describe certain features over there. Okay. First, we will discuss these lines so that you have an idea so how we can properly visualize this PNS view are also called as OM, occipitomental view. There are three lines called Doland lines, DOLAN apostrophe S, Doland lines. And these lines are OZM. O stands for orbit, Z for zygomatic bone, and M for maxillary. Here is this medial line is the orbital line. This is from inforbital margin and on the medial orbital margin also. Especially on the inforbital margin, if it is there, then this will also signify the presence of some zygomatic bone fracture. And then the second line is the zygomatic line coming from the lateral orbital rim, from its outer aspect, and then on the upper aspect of the zygomatic arch. These are the imaginary lines which you can consider in your mind, or you can draw in your mind while visualizing this PNS view, so as to properly assess the zygomaticomaxillary complex fractures. For other midfacial fractures, there are also certain other lines. At the moment, I will not discuss those lines because these are not in the domain of this lecture. But in these Doland lines, these are directly related with the radiological examination of the zygomaticomaxillary complex fracture. And among these lines, the first line is the orbital line on the inforbital margin, then come towards the medial orbital wall. The second line is along the suborbital margin and lateral orbital margin, and on the spear aspect of the zygomatic arch, going posteriorly on the zygomatic arch. The third line is along the whole of the zygomaticomaxillary buttress region. This is zygomaticomaxillary buttress region where I am moving this yellow cursor. Zygomaticomaxillary buttress. Once you draw these three lines and you point out this zygomaticofacial foramen over there, this red dot, or on the right side this green dot, and you draw this arch also. This arch, it is just like the trunk of an elephant. And while drawing these lines, this orbital area, it will show just like the head of an elephant. And this dot will just the eye of the elephant. And once you draw these lines, these are just like the head and trunk and eye of the elephant. And this typical is labeled as elephant of Roger Moore. This typical picture of the imaginary lines drawn on PNS view, that is OZM, Oz. O stands for orbit, Z for zygomatic, and M for maxillary. Once you visualize your PNS view along these lines, you will not going to miss any of the radiological feature of the zygomaticomaxillary complex. Now coming towards this right side radiograph, here, look here on the lateral aspect, there is step deformity. There is separation sign due to fracture. Coming down towards the inforbital region, there is gap, there is separation, and the fracture line comes down towards the zygomaticomaxillary buttress region. In this way, and posteriorly here in the arch region. In this way, this whole zygomatic bone has get displaced or get fractured from the here from frontal bone and here from maxillary bone. And here this projection is the coronoid process. And there is on the right side also in zygomaticomaxillary buttress region, there is also fracture, and on the inforbital region also. And here on the right side there is LIFO2 fracture, on the left side there is zygomatic bone fracture. And also in these PNS views, look here on this right sided picture of PNS view, where I will on the left side this is projection of the coronoid process over there. And this is the main body of zygomatic bone, and there is some distance between the tip of coronoid as well as the body of zygomatic bone. And this distance allows the mandibular bone and its coronoid process to move freely. But once, like here on the right side, there is fractured zygomatic bone. There is depressed zygomatic bone, and the coronoid process, either it directly merges with the zygomatic bone, or the distance on the fractured side could be decreased from the tip of the coronoid process and the main body of the zygomatic bone. Once the distance is decreased, while mandibular movement, there could be restriction in the movement of the coronoid process. This will lead to limited mouth opening. And this is also one of the radiological feature of of the zygomatic complex fracture that on the affected side, the distance between tip of the coronoid and the body of the zygomatic bone will get decreased. Moreover, like in this right side picture in the PNS, there is haziness of maxillary sinus. There is disruption on this radiograph. On the left side, the zygomaticomaxillary complex, zygomaticomaxillary buttress region, the proper shape of the buttress is there on the left side. But on the right side, there is disruption. There is fracture line. There is haziness of maxillary sinus also, which signifies the presence of fracture over here. And this coronoid was removed in the one patient having limited mouth opening, so as to treat the limited mouth opening due to zygoma fracture. Also, in this slide, in the very first picture on the left side, there is decreased distance of the coronoid process from the zygomatic bone, where I am highlighting this. But there is some space on the left side between the tip of coronoid and the body of zygomatic bone. And this decreased distance also signifies the presence of the fracture of the zygomatic bone. And here in this lower picture, again, there is step deformity in the buttress region. Here, haziness of maxillary sinus, and also step deformity at this infraorbital region, and separation sign at lateral orbital region also, which signifies the left zygomatic bone fracture over there also. In these radiographs, there are multiple fractures, and there is on the radiograph on the left. First, we will discuss this one. There is displacement of frontal process zygomatic bone, and there is separation at the frontal zygomatic suture. Look here, and also at infraorbital